Welcome back to the deep dive. Today, we're zoning right in on tuberculosis TB.
Yep, TB.
Think of this as your focused revision session. We want to give you that critical knowledge, especially if you've got the MSRA coming up.
Absolutely.
Revision can feel pretty overwhelming sometimes, can't it?
Yeah.
So our goal here is simple. Pull out the really essential stuff, the exam-relevant bits, and make them stick.
Exactly. TB is definitely a key topic for the MSRA, and, it can show up in so many different ways. So the aim is to build that comprehensive picture, but keep it concise.
Yeah.
We'll cover everything, basically, from what it is, right through to complications. And we'll try to use some memory aids, point out those exam-critical details.
Perfect. So this deep dive into TB, our mission is cover all the core stuff. We'll kick off with the definition, then the cause, the etiology. Then look at who's most at risk factors. Dig into how it works, pathophysiology. Think about what else could be the differentials.
Yeah.
Look at who gets it, where epidemiology, how it actually presents clinical features, how we diagnose it, investigations.
Crucial stuff.
How we manage it, the likely outcome prognosis, and finally, what can go wrong, complications. Okay, let's dive straight in.
Okay.
What exactly is tuberculosis?
Okay, so fundamentally, TB is a contagious infection caused by bacteria. It primarily hits the lungs.
Primarily the lungs.
Yeah, but that's key, primarily. The bug causing it is Mycobacterium tuberculosis. And while lungs are the most common spot, it's really important to remember TB can spread. It can affect kidneys, the spine, the brain.
Wow, okay.
The GI tract, central nervous system, even the vertebral bodies, the bones in your spine, kidneys again, the pericardium, that sac around the heart. It can get around.
So definitely not just a lung thing. That's a critical point right there. How does it actually spread between people?
It's airborne. Simple as that, really. When someone with active TB in their lungs coughs or sneezes, speaks, even sings.
They say it's okay.
Yeah. They release these tiny little droplets into the air, and those droplets contain the bacteria. If someone else breathes those in, they can get infected.
Okay, so you breathe it in. What happens next inside the body? Walk us through that sequence.
Right. So once you inhale the bacteria, they get picked up by immune cells called macrophages. These macrophages carry them to the hilar lymph nodes. Those are the nodes near the main airways in the lungs. The body then tries to wall off the infection. It forms these structures called granulomas or tubercles. Think of it like the body trying to build a little containment unit around the bacteria using immune cells.
Like a defensive wall.
Exactly. Now, from this point, a few things can happen. The immune system might actually clear the infection completely. That's one outcome.
Okay.
Or the bacteria might just become dormant. They're alive, but contained within that granuloma wall. This is latent TB. The person isn't sick. They can't spread it.
But the bacteria are still there.
They are. And if the immune system weakens later on, for whatever reason, that wall can kind of crumble. The bacteria escape, start multiplying, and boom, you've got active TB disease.
Okay, that makes sense. And what about miliary TB? We hear that term.
Right, miliary TB. That happens usually during the initial primary infection. The bacteria manage to get into the bloodstream and spread throughout the whole body. They form these tiny, tiny lesions everywhere, almost like scattered millet seeds, hence the name miliary. And then there's secondary TB. This is usually when that dormant latent infection reactivates, often years later. And typically, this reactivation happens in the upper parts of the lungs, the apex.
Got it. And we can't really talk about TB today without mentioning drug resistance, can we? It seems like a huge problem.
Oh, it's a massive issue, a growing global health crisis, really. We're seeing more and more multi-drug resistant TB, that's MDR-TB, resistant to at least the two main drugs, isoniazid and rifampicin.
Right.
And even worse, extensively drug-resistant TB, XDR-TB, which is resistant to even more drugs, including second-line options. It makes treatment incredibly difficult.
I can imagine. What are the numbers like?
Well, some data from back in 2012 estimated around 450,000 cases of MDR-TB globally. Higher rates in places like Eastern Europe, parts of Asia, Southern Africa. It's tied into issues like people not finishing their treatment course, maybe inconsistent drug supplies. It's complex. Needs global effort.
So, wrapping up the definition. Contagious bacteria, Mycobacterium tuberculosis, Mainly lungs, but can spread. Airborne transmission, latent or active forms, and drug resistance is a major global headache. Right, let's move to etiology, the cause.
Well, as we've sort of covered, the one and only cause is the Mycobacterium tuberculosis bacterium itself.
Simple as that.
Pretty much. And the way it spreads is person to person via those airborne respiratory droplets when someone infectious coughs, sneezes, talks, that whole routine.
Okay, straightforward. Now, risk factors. Who's actually at higher risk of developing active TB? Let's unpack those.
Yeah, there are several key groups. Number one is definitely close contact with someone who has untreated infectious TB. Makes sense, right? More exposure.
Stands to reason.
Second, ethnic background can play a part. People originally from areas with high TB rates, like South Asia or sub-Saharan Africa, generally have a higher risk when living elsewhere, too, sometimes due to latent infection acquired previously.
Okay.
And it's interesting, you notice how factors like homelessness, substance abuse, even ethnic background in some contexts, they often link back to socioeconomic factors.
Yeah, definitely. Poverty, poor nutrition, crowding.
Exactly. It shows TB isn't just purely a medical thing, it has deep social roots. That's important for understanding why it persists.
Good point. What are the risk factors?
Homelessness and substance abuse are big ones, often tied to those factors we just mentioned: poverty, malnutrition, crowded living, which all weaken the immune system.
Right.
Then, critically, anyone who is immunocompromised, so people with HIV/AIDS, those on immunosuppressant drugs, maybe after a transplant or for autoimmune diseases, or anyone with a weakened immune system for other reasons.
So anything that lowers the body's defenses makes you more vulnerable.
Precisely. The elderly are also at higher risk. Often this is due to reactivation of a latent TB infection they might have had for decades without knowing.
Ah, the reactivation point again.
Yep. And then other health conditions, things like really debilitating diseases, long-term steroid use, diabetes is a significant one, even having had certain types of surgery like a gastrectomy.
Yeah, and children.
Children are more vulnerable because their immune systems are still developing. But an important point, children with TB are usually not very infectious themselves. They're less likely to spread it.
That's a key distinction for transmission, yeah. Wow, that's quite a list of risk factors.
Yeah.
Any easy way to remember some key ones for an exam?
Well, you could try a mnemonic, maybe something like CHEST-HII.
CHEST-HII. Okay, break it down.
C for close contact, H for homelessness, E for ethnic background from those high prevalence areas, S for substance abuse, T for the elderly, another H for HIV or immunocompromised, and I for other illnesses like diabetes or steroid use. It hits some main categories.
CHEST, like C-H-E, H-T-H-I. Yeah, that's actually pretty helpful. I group them together nicely. Okay, let's get into the pathophysiology. What's actually happening biologically when someone gets infected?
Right, so we touched on this. It starts with breathing in the M. tuberculosis bacteria. That immediately kicks the body's immune response into gear. Now, in a lot of people, maybe most, this initial immune response manages to get the bacteria under control. It doesn't eliminate them completely, but it contains them. This leads to latent TB infection, LTBI.
The dormant stage.
Exactly. Bacteria are alive, but inactive, walled off. The person feels fine, is infectious, but, and this is the key bit, if that person's immune system gets weaker later on because of HIV or medication or age, any of those risk factors we listed, those dormant bacteria can wake up, reactivate, start multiplying, and that's when you get active TB disease.
Okay. And down at the cellular level, inside the lungs, what's going on?
So the bacteria are quite clever. They actually invade the immune cells themselves, particularly macrophages in the lungs.
They hide inside the defenders.
Sort of, yeah. This invasion triggers inflammation. And as the body tries to fight back and isolate these infected cells, it forms those granulomas, the tubercles we mentioned. These are organized clumps of immune cells basically trying to wall off the infection.
The containment strategy.
Precisely. In latent TB, these granulomas work pretty well. They keep the bacteria locked down. But in active TB, the bacteria basically overwhelm this containment. They multiply inside the granulomas. The granulomas can break down, causing tissue damage, and the bacteria can then spread.
So it's like a constant battle between the bacteria trying to break out and the immune system trying to keep them contained.
It's a real tug of war, exactly. And the granuloma is that battlefield structure. Its success or failure determines whether you have latent or active disease.
Makes sense. Okay, so when a patient comes in with symptoms that could be TB, what else should be on our minds? What's in the differential diagnosis?
This is super important because TB can look like a lot of other things. especially pulmonary TB. You absolutely have to consider other lung infections like bacterial pneumonia or fungal infections.
Okay.
Lung cancer is a major differential, especially if you see certain things on a chest X-ray. Other granulomatous diseases like sarcoidosis can also mimic TB.
Sarcoidosis, right.
Then you've got more common things like bronchitis, though usually the symptoms are different. Other cancers like carcinoma or lymphoma need consideration. If someone presents with a fever that you can't explain a pyrexia of unknown origin, PUOTB has got to be on that list.
Definitely.
And don't forget other lung diseases that cause fibrosis, like hypersensitivity pneumonitis, or occupational lung diseases like pneumoconiosis or silicosis.
Okay.
And finally, sometimes chronic conditions like anorexia nervosa or diabetes might present with some overlapping symptoms like weight loss, or they just increase the risk, so they're relevant to keep in mind too.
That's a pretty wide net we need to cast then. Really highlights how varied TB can look. Okay, let's shift to epidemiology. Who gets TB and where? What's the picture like here in the UK?
Right, so in the UK, the overall numbers have been going down, which is good news. But it's definitely still a public health issue, particularly in certain groups.
Which groups mainly?
We see higher rates in people who've immigrated from countries where TB is much more common. Also, people living with HIV and individuals who inject drugs. Those are key populations.
And any recent figures?
Looking at, say, 2019 data, the incidence rate was about 9.4 cases per 100,000 people. That worked out to just over 4,400 reported cases that year.
Okay. And is it spread evenly across the country?
Not really, no. There are regional variations. You tend to see higher rates in big cities. London, for example, accounts for something like 40% of all the TB cases in England.
Wow, 40% in London.
Yeah. And the trend is interesting. Cases actually went up between 2000 and 2011, but since 2012, there's been a steady annual decline. By 2017, the rate was down to 8.4 per 100,000, which was the lowest since they started collecting that data back in 2000.
So decreasing overall, but concentrated in specific groups and urban areas. What about globally?
Globally, it's a completely different scale. TB is still a massive killer. It's the second biggest cause of death from an infectious disease worldwide, right after HIV.
Second only to HIV.
Yeah, and it causes about 1 in 5 deaths among people who have HIV. The sheer number of people affected is staggering. Estimates suggest about 23% of the entire world's population, that's like 1.7 billion people, have latent TB infection.
1.7 billion people with latent TB. That's incredible.
It really puts it into perspective, doesn't it? So while the UK situation is one thing, globally it remains a huge, huge challenge.
Absolutely. Okay, so we know who gets it and where. How does it actually show up in patients? Let's talk clinical features.
This is where it gets tricky again, because the presentation is just so varied. But there are definitely common signs and symptoms of active TB to look out for.
The classic one.
Yeah, the ones you usually think of. A persistent cough, often lasting weeks, often producing sputum, sometimes phlegmy, chest pain, losing weight without trying, feeling really tired, fatigued, fevers, especially in the evenings, and those classic night sweats, waking up drenched.
Night sweats, right.
And in more advanced disease, you might see hemoptysis, coughing up blood. That's usually a later sign.
Okay. Any other general symptoms?
Yeah, people might lose their appetite, anorexia. You might find enlarged lymph nodes, particularly in the neck. A key thing is that TB often creeps up on you. It has an insidious onset. It develops gradually.
So it might not be obvious straight away.
Exactly. And remember that initial primary infection is usually asymptomatic. People often don't even know they've been exposed or infected at that stage. It's usually the secondary infection, the reactivation, that brings on the noticeable symptoms.
And that reactivation can present differently depending on where it is in the body, right?
Absolutely. Extrapulmonary TB outside the lungs is more common in kids and the immunocompromised. And it can look very different.
Give us some examples. How might it present elsewhere?
Okay, so pulmonary, we've covered chronic cough, sputum, maybe pneumonia-like picture, genitourinary system. You might see sterile pyuria, that's white cells in the urine but no bacteria on standard culture. Kidney lesions. In women, maybe infertility. In men, perhaps a swollen epididymis.
Okay.
Musculoskeletal. Could be bone or joint pain, arthritis, abscesses forming, maybe nerves getting compressed if it's near the spine, CNS involvement, headaches, neurological signs, meningitis is the big scary one there,
Okay.
GI tract, abdominal pain, and maybe bowel obstruction, fluid in the abdominocytes, lymph nodes. In large nodes, sometimes they can break down and form discharging sinuses to the skin. Skin itself, You might see things like erythema nodosum, those painful red lumps, usually on the shins or skin sinuses, and the heart. If it affects the pericardium, you could get fluid buildup, pericardial effusion, or even constrictive pericarditis where the sac gets stiff.
Wow. It really can pop up almost anywhere. It just reinforces that need for a high index of suspicion and getting that diagnosis and treatment started early. So how do we diagnose it? What are the key investigations?
Investigations are absolutely critical, both for spotting active disease and finding that latent infection. For active TB, a common first step is looking at sputum under the microscope after a special stain, the Zeal-Nielsen stain, to see if we can spot acid-fast bacilli, or AFBs. That's characteristic of Mycobacteria.
Okay, the AFB smear.
Yep. Then we have nucleic acid amplification tests, NATs. These are great because they're much faster than culture, detecting the bacteria's DNA directly from the sample.
Faster is good.
Definitely. But culture is still the gold standard. Mycobacterial culture lets us grow the actual bacteria, confirm its M. tuberculosis, and importantly, test which antibiotics it's sensitive to. The downside: it takes time, usually several weeks on special media, like the Lowenstein-Jensen slope.
Weeks, okay. So you might need to start treatment before culture results are back.
Often, yes, if the suspicion is high. We also nearly always get a chest x-ray to look for typical signs in the lungs like infiltrates, cavities, often in those upper lobes we mentioned for reactivation.
Right.
Now, for latent TB, we're not looking for the bacteria itself, but the body's immune response to it. That's where the tuberculin skin test, the TST or MAN2 test, comes in, or the blood tests called interferon gamma release assays, IGRAs.
Okay, MAN2 and IGRAs for latent.
Exactly. And another really important tool now, especially for active disease, are molecular tests like the expert MTBRF assay. These can rapidly detect M. tuberculosis DNA and tell you if it's resistant to rifampicin, one of the key drugs. That's huge for guiding treatment early.
That rapid resistance testing sounds vital.
It is. And of course, if we suspect TB outside the lungs, we might need biopsies of the affected tissue or other imaging like CT scans.
Tell me a bit more about screening for latent TB with the MAN2 test. How does that work?
Sure. The MAN2 involves injecting a tiny amount of tuberculin protein just under the skin, usually on the forearm. Then you wait 48 to 72 hours and measure the diameter of the induration. That's the hard raised bump that might form.
Okay. And how do you interpret the size?
Well, the cutoffs can vary slightly depending on guidelines and the person's risk factors, but generally, less than 5 or 6 millimeters is usually considered negative. Someone might be a candidate for BCG vaccination if they're negative and at risk.
Right.
Between about 6 and 15 millimeter, that's trickier. It could mean they've had the BCG vaccine in the past, or it could mean latent TB infection.
Ah, the BCG confusion.
Exactly. And that's where IgRAs are often preferred now, especially in BCG-vaccinated populations, as they're not affected by prior vaccination. Then, an induration greater than 15 millimeters is generally considered a strong indicator of TB infection, latent or possibly active.
Right. So a positive MAN2 doesn't automatically mean active disease. It just suggests infection at some point.
Correct. It indicates likely latent infection needs further assessment.
Okay. When you do suspect active TB, how do you handle getting those microbiological samples?
Good practice is to request those rapid in-ets on the first samples if you have a strong clinical suspicion. But for a firm diagnosis and sensitivities, you need culture. For suspected lung TB, the aim is usually to get at least 3 separate sputum samples, ideally collected early morning, sent for microscopy, that ZN stain for AFBs and culture.
3 samples.
Yeah, increases the yield. And again, if you strongly suspect TB clinically, don't wait weeks for the culture results. Start treatment based on clinical judgment and maybe the smear or NET results.
Right. And for non-respiratory TB?
Then you'd be looking at samples from the suspected site, maybe a biopsy of a lymph node, fluid from the abdomen or around the lung, urine samples if you suspect GU, TB, joint fluid, whatever is appropriate. Send those for microscopy, culture, and histology if it's tissue. And again, trait if the picture fits, even before culture confirmation.
How long do those sensitivity results take?
Standard culture sensitivities take maybe 3-4 weeks after the culture first grows, which itself can take weeks. So it's a while. That's why those rapid molecular tests for rifampicin resistance are so valuable up front.
Definitely. Any other lab tests that are standard?
Yes, absolutely crucial to test for HIV, and usually hepatitis B and C as well, as these co-infections impact management.
Right.
We might use rapid molecular probes on primary samples if knowing the result quickly would change management or is needed for contact tracing. But, important point, for suspected TB meningitis, you start treatment empirically immediately based on suspicion. Even if rapid tests are negative initially, It's too dangerous to wait.
Don't delay for meningitis. Got it.
And if you suspect MDR-TB, you'd use rapid rifampicin resistance tests, put strict infection control measures in place, and start an appropriate MDR regimen while waiting for full sensitivity results from culture.
Makes sense. And finally, on investigations, what about screening people who've been in contact with an active case?
Contact tracing is key. Close contacts, like people living in the same house, need to be assessed. This usually involves testing for latent TB infection, often starting with a MAN2 or an IGRA.
Okay.
NICE guidelines often suggest using IGRAs, sometimes after a MAN2, or if MAN2 results might be unreliable, like in BCG-vaccinated people. If the MAN2 is borderline or inconclusive, they should be referred to a TB specialist.
Right. Get the experts involved if it's unclear.
Right.
Okay, that's a really thorough look at investigations. Let's move on to the really crucial bit management and treatment.
Okay. The absolute cornerstone of TB treatment is using a combination of antibiotics for a long time, and sticking to the plan adherence is absolutely vital. Non-adherence is how we get drug resistance.
Combination and duration.
Got it.
So, for standard active drug-sensitive TB, what's the regimen?
It's usually a two-phase approach. First, an intensive phase for 2 months. This uses 4 drugs. The mnemonic RIPE helps here.
RAPE. Remind us.
R is for rifampicin, I for isoniazid, P for pyrazinamide, and E for ethambutol. So RIPE for 2 months.
Okay, RAPE, 2 months, then what?
Then comes the continuation phase. This usually lasts for another 4 months and typically uses just 2 drugs, rifampicin and isoniazid. So the total treatment duration for standard pulmonary TB is usually 6 months.
6 months minimum. Are there exceptions?
Yes. TB meningitis, for example, needs much longer treatment, usually at least 12 months. And often steroids are added in meningitis cases to reduce inflammation and complications.
12 months for meningitis plus steroids.
Yep. And obviously, drug-resistant TB is a whole different ballgame. That needs specialist assessment, tailored regimens with second-line drugs, and very close monitoring, often much longer treatment, too.
Okay. And if the patient also has HIV?
That needs careful management, usually following specific guidelines like the British HIV Association, BHIVA1s. You have to consider potential drug interactions between the TB meds and the antiretroviral therapy.
Right, those interactions again. What about treating latent TB infection?
Treatment for LTBI, sometimes called preventive therapy, is recommended for people who are found to have latent infection and are at higher risk of it progressing to active disease.
Who gets offered LTBI treatment?
People with recent infection, like close contacts, those with HIV, people about to start immunosuppressants, like anti-TNF therapy, those with certain medical conditions like silicosis or kidney failure on dialysis. The criteria are quite specific.
Okay. And what's the treatment?
There are a few options. A common one used to be isoniazid on its own for 6 or even 9 months. More often now, shorter regimens are used, like 3 months of weekly isoniazid and rifapentine, or 3 to 4 months of daily isoniazid and rifampicin.
Short regimens are good for adherence, I guess.
Exactly, and sometimes to really make sure people take the meds, especially for LTBI, or if adherence is a concern with active TB, directly observed therapy, or DOT, might be used. That's where a healthcare worker literally watches the patient swallow their pills.
DOT. Okay. Beyond the drugs, what are the broader aspects of managing TB?
Well, first off, TB is a notifiable disease in the UK. Every case must be reported to public health authorities.
Right, for tracking and tracing.
Absolutely. Public health policies are key for prevention and control. We need to think about isolation for infectious cases, usually in hospital initially, until they're non-infectious, typically after about 2 weeks of effective treatment. Regular monitoring for side effects is crucial, especially liver function tests, because several TB drugs can affect the liver.
We'll come back to side effects.
Yep. DOT, as we mentioned, helps adherence, particularly for groups like homeless people or those with substance misuse issues. And sometimes surgery might be needed for complications, like draining a large abscess or removing destroyed lung tissue.
Okay. Any differences for children with LTBI?
Yes, specific regimens are used for children, again, because their risk of progressing from latent to active disease is higher. And preventive therapy for LTBI is definitely offered to high-risk individuals.
You mentioned side effects of the first-line RIP drugs. Let's go through those again, key ones for the MSRA.
Definitely need to know these. Rifampicin, isoniazid, and pyrazinamide all carry a risk of hepatotoxicity, liver damage. So baseline liver function tests, LFTs, before starting, and monitoring during treatment is essential, especially if someone has pre-existing liver disease or drinks heavily.
Okay, liver toxicity from RINP. What else?
Isoniazid can cause peripheral neuropathy, tingling, numbness in hands and feet. We usually give pyridoxine, which is vitamin B6, alongside isoniazid to prevent this.
B6 with isoniazid for nerves. Got it.
Ethambutol. The big one is optic neuritis. Affects vision, color vision especially. Patients need baseline eye checks and need to report any visual changes immediately. Regular monitoring of visual acuity is recommended.
Eye checks for ethambutol
Okay.
and rifampicin.
Apart from liver toxicity, the really key thing about rifampicin is that it's a powerful enzyme inducer in the liver. It speeds up the metabolism of many other drugs.
The drug interactions.
Exactly. This is huge. It can reduce the effectiveness of lots of common medications, oral contraceptives, warfarin, certain anti-epileptics, HIV drugs. The list is long. Always need to check for interactions when starting rifampicin. Oh, and it turns body fluids, orange, red urine, tears, sweat. Need to warn patients about that.
Orange tears. Good practical point. What about second-line drugs? Used when?
Second-line drugs come in for drug resistance, MDR, XDR, TB, or if someone absolutely cannot tolerate the first-line agents. These are definitely specialist territory. Examples include injectable agents like amikacin or capreomycin, fluoroquinolones like moxifloxacin, cycloserine. They often have more side effects and require even closer monitoring.
Okay, specialist drugs for complex cases. So, summing up management. Long course, combination therapy, adherence is king, monitor side effects closely, especially liver and eyes, be very wary of rifampicin interactions, and specialist input for resistance.
Right.
What's the outlook usually? Prognosis.
Generally, with the right treatment started promptly, the prognosis for drug-sensitive TB is actually very good. Most people make a full recovery, achieve a cure.
That's good to hear.
Yeah. Early diagnosis and starting treatment quickly are the biggest factors for a good outcome. The challenges come in with drug resistance, obviously, or if diagnosis is delayed, or if the person has other serious health problems, comorbidities.
Makes sense.
And I can't stress enough, finishing the entire course of treatment is absolutely critical. Stopping early at how resistance develops and increases the risk of relapse later.
So adherence again?
Always. Without treatment, TB can be fatal, especially severe forms like miliary TB or TB meningitis.
So detect early, treat fully good prognosis. Don't, and it can be very serious. Finally, complications. What can go wrong even with treatment?
Well, drug resistance is a major complication in itself, making treatment much harder. The side effects of the drugs we discussed, hepatotoxicity, neuropathy, optic neuritis, are complications of the treatment.
Right.
Relapse can happen, the disease coming back after finishing treatment, often due to resistance or maybe inadequate treatment duration initially. TB can cause permanent organ damage, particularly in the lungs, things like pulmonary fibrosis, scarring leading to chronic breathing problems or respiratory failure.
Long-term lung damage.
Yep. Spreading outside the lungs, dissemination leading to extrapulmonary TB is a complication. If TB is very severe or goes untreated, it can lead to death. HIV co-infection makes everything more complicated and increases the risk of poor outcomes.
And you mentioned iris.
Yes. Immune reconstitution inflammatory syndrome. This can happen usually in HIV-positive patients shortly after they start either TB treatment or their HIV treatment. Their recovering immune system suddenly reacts strongly to the TB bacteria, dead or alive, causing a paradoxical worsening of symptoms like lymph nodes getting much bigger, fevers returning. It needs careful management, sometimes with steroids.
Okay, iris. That's important to know about. How do we try and prevent these complications?
Prevention really boils down to the basics we've covered. Diagnose early, start the right treatment promptly, monitor carefully for those drug side effects LFTs, asking about neuropathy symptoms, regular vision checks for ethambutol, giving pyridoxine with isoniazid helps prevent neuropathy, and again, ensuring full treatment adherence is the best way to prevent resistance and relapse.
Okay, this has been incredibly thorough, a real deep dive into tuberculosis, covering so much ground.
Absolutely. We've gone from the basic definition, the cause, the risks, how it works biologically, what else it might be, the stats, how it looks clinically, all the investigations, the complexities of management, right through to prognosis and complications.
Yeah, the aim was really to pull out that essential knowledge, the stuff you need to feel confident about TB, especially for the MSRA.
Hopefully we've distilled it down, whether it's remembering the right PE regimen, the side effects, or that CHEST-HII mnemonic for risk factors.
CHEST-HII. Still like that one.
Hopefully this gives a solid foundation, and definitely revisit bits if you need to reinforce them.
Absolutely. And for more great resources as you prep for the MSRA, Do check out pastsea.com.
And also freemsra.com for loads of free questions and revision materials.
Excellent plugs. Thank you so much for joining us for this deep dive into tuberculosis. We really hope you found it useful for your revision.
Good luck with the studying.
Until the next deep dive.